request all the students to put forward their questions along with their names by typing in the chat box so that I can put it before the speakers at the end of all the sessions. Okay. So the first session is on the etiology and investigation of infertility to be taken by Dr. Beenal Shah. She is the Vice President of Vadodara Menopause Society, past President BOGS. She is MD Gold Medalist and has done diploma in gynec endoscopy in Germany, and she has won several awards for best paper and video in the past. I request ma'am to start with the session. Thank you.
Yeah, good morning, everybody. Respected seniors, teachers, and my dear friends and my colleagues. So, this is a very important discussion which we are going to do today because fertility is so close to human species. Like, this is how our species propagates. So, fertility is the most vital thing for the pregnancy and the species of the humans to continue. But then many of us are facing like in day-to-day OPT, lot of couples coming in with complaints of infertility. So this was a landmark in the history of infertility when the first test tube baby Louis Brown was born, that is in 1978. And since then, the treatment of infertility has gone leaps and bounds. And although, yeah, I mean, looking to the population of India, we would not say that there is infertility, but mind well, to the ones who are infertile, it is the how would you define infertility? It is inability to achieve pregnancy in a year of unprotected intercourse. Primary infertility is when the person has never been able to conceive. Secondary outcome, like I mean, whether it was a live born or an abortion or ectopic, irrespective of the outcome, if there is a subsequent failure to conceive, so that is secondary infertility. And nowadays, infertility is increasing. So why is it on the rise? The common reasons which are delayed marriage, delayed childbearing, sexually transmitted diseases are on a high. Then increasing number of abortions, some tubal blockage or endometritis, environmental pollution. So there are many causes why the infertility is on a rise. Now, what we need to explain to the couple is that of variation according to the ethnic background. Like you cannot compare that in the European or the Americans, they are marrying after 35 and conceiving after 40. Like for the Indian Asian biological clock for the female, it ticks faster and the fertility potential goes down as especially as the female ages. More so for the female, that after 30, the fertility potential reduces, and especially after 35. So all infertility specialists and people working in the fertility segment will agree to it that the most important factor in fertility management is the age. Like if you have age on your side, the chances of result are better. Now, what are the factors which are essential for conception? So, what you need is a healthy sperm, motile sperm. You need a ovulation, and you need the sperm to move across the fallopian tube to fertilize. Now, this is something very basic. I mean, there's no rocket science in this. But the causes of infertility obviously are related to problem in any of these basic steps, right? So, male partner is so. One more very important thing is like when I'm talking about the history taking, that never treat it as a male infertility, female infertility. It is always the couple whom you have to take into consideration. Male is responsible for approximately 30% to 40%. Female, approximately 40 to 50% of causes, and often 10% are combined causes. And although books say that 10% are unexplained, but in practical practice, we have seen that almost 20% are unexplained infertility. So history taking is very important about their past, whether they are on any medications, whether there have been any surgeries which they have undergone, and what is their lifestyle, because stress is also an important factor. So first of all, whenever an infertile couple comes, counseling is very important, explaining them the correct technique, the fertile period, the timed intercourse. I mean, this is underemphasized, but it is very vital. And the jokes were being shared that this during this lockdown, many unexplained infertility couples conceived because they had quality time together. So this is very important. What is the see now? If you will search, there is a lot of long list of causes and investigations which you can do for an infertile couple. But what is the concept which is to be kept in mind is that a simplified approach will lead to reduction in the time and cost of investigating an infertile couple. So these are the very, very basic investigations. For the male, the semen analysis; for the female, the basic investigations, that is the hemoglobin, blood group, sugar, thyroid, and prolactin are important. Ultrasonography is the main tool in the armamentarium of the gynecologist because it provides a lot of information about the reproductive tract, the uterus, the ovaries, the fallopian tube, any pathology. And nowadays, with the advent of 3D ultrasound, often, the terminology, that is the diagnostic laparoscopy, is totally outdated. Like majority of the things, 99%, you are able to diagnose with a non-invasive modality, that is the ultrasonography. So ultrasonography transvaginal is preferable, and follicular monitoring study gives us a lot of information about the ovulation pattern, anovulation, and persistent luteinized follicle and all, and the tubal pittance. So these are the basic reports or investigations which couple should be undertaken. Now, as the topic given to me was the causes, so I'll just to complete the list, I'll enumerate the causes, but then I'll also emphasize which are the important ones. So in the male infertility, pre-testicular causes are like the endocrine, like the gonadal deficiencies. Obesity is now a pandemic. Thyroid and hyperprolactinemia. Psychosexual, again, is a very important cause nowadays with a lot of stress and a lot of work pressures, target-based approach, like the erectile dysfunction, impotence. If the male is on some drugs like antihypertensives, antipsychotics, again, that could reduce his fertility potential. And sometimes there can be genetic problems like 47XXY, Klinefelter's Y chromosome deletion, single gene mutations. So those were the pre-testicular causes. Now coming to the testicular causes, there are immotile cilia, cryptorchidism, like the undescended testes is there. And suppose it is not timely repaired. I mean, if an infant is born with a testes which is not at the proper location, and if that testis remains intra-abdominal, so then that testis loses its function. Also go for the history of in mumps orchitis, especially in the childhood, can lead to testicular cause of infertility. Again, smoking is very rampant. It is considered as a for trend or a fashion. Smoking, in even tobacco chewing and radiation, like the people in the X-ray or the orthopedic department who are exposed to radiation, they can have testicular cause of the infertility. Varicoceles increases the local temperature and reduces spermatogenesis. Immunological causes, Sertoli cell syndrome, primary testicular failure. Just like we have a primary ovarian failure, we can have a primary testicular failure. Oligoestenozoospermias with abnormally morphologically and immotile sperms. So these were the testicular causes, and the common ones are the infection, the toxins, and the varicocele. Now, the post-testicular causes are the obstruction to the efferent duct, that is the congenital absence of vas. Acquired causes can be tuberculosis, gonorrhea, and there can be a history of surgery which has led to the obstruction. And other causes would be ejaculatory failures, retrograde ejaculation, especially post-surgery for the prostate, hypospadias, and bladder neck surgeries. So that was to complete the list of infertility in males. But mind well, in the investigation part, semen analysis, that is the mainstay of investigating a male partner. So we require at least 2 samples, preferably 6 weeks apart. The collection has to be by masturbation. Abstinence has to be minimum for 2-3 days and maximum for 7 days prior to the sample collection. Preferably not collected when the person is having fever. A lab collection is preferred. The temperature, the sample has to be at the body temperature. So excess heat or excess cold can destroy the sperms and give us a wrong report, right? So do never rely on just a single report. And nowadays these are these automatic analyzer machines, so they give a more accurate report. So insist for a SQA analyzer and an accurate report. Also meanwhile explain the male the side effects, like whenever you have a couple with you, never miss the chance of counseling or putting forward, like besides the medicine these things work better. So the side effects of tobacco, ask him to quit, and excess heat exposure, stress, all those things are very vital. Now, these are the WHO criteria for a normal semen analysis with at least a concentration of 20 million per ml. And even 25% of fertile males have concentrations even less than this. So it is not the absolute concentration which is important, but the quality and the of the morphology of the sperms. Motility is very, very vital because the sperms have to reach the ovum, the target. So minimum 50% of progressive forward motility is important. Morphology, again, these percentage keep on changing. Like in 2010, WHO defined, because these are mentioned in the textbook, so I've mentioned this, that more than 14% normal forms. But nowadays, the latest reports say that even more than 5% normal morphology can give you fertility. And also have a look at the fructose which has to be present, and leukocyte count has to be low, because if there is infection in the semen, then also that can lead to infertility. Now coming to the female causes of infertility, again you have to consider the female reproductive organs. The ovulatory dysfunction is responsible for almost 30 to 40% of causes of female infertility. Tubal disease accounts for 25 to 35%, uterine factors are 10%, cervical factors 5%, and pelvic endometriosis 1 to 10%. Now, again, according to the geographical and ethnic distribution, the endometriosis incidence would vary. So, what are the investigations in female? As I already said, that we'll be doing the basic blood investigation, the thyroid, because even hypothyroid can lead to problem with the HPO axis. So, even borderline hypothyroid, like the TSH levels, which are recommended for females who are planning fertility and pregnancy, is less than 3.5. Whereas for the routine population, we consider the upper limit of 5 for the TSH, right? So, even borderline hypothyroidism should be corrected. If you have a history of oligo or anovulation or galactoria, definitely you have to see for the prolactin and correct the hyperprolactinemia. Now, assuming that other reports are already normal. One more thing I would like to again re-emphasize is that never miss the male partner investigation, and that should be the first thing to do, the semen analysis. Like we in the day-to-day OPD, we see patients with files and files of investigations of the female and not even a single semen analysis report. So that should not be done. Okay, now coming to the investigations in female, as I said that ovulatory factors are one of the major factors. We need to confirm whether the ovulation is occurring in time. That can be done with the help of a menstrual history, where she gives a regular menstrual history. BBT, that is the basal body temperature. These are age-old things which are mentioned in the textbooks. You should be aware about it, but in practice, we are not doing it much. So progesterone being a thermogenic hormone, in the second half of the cycle, you see a 1 degree Fahrenheit rise. Cervical mucus study is there for their hostile cervical mucus. Hormone estimations are there, like the mid-cycle progesterone. Again, very important home-based, like for example, in this lockdown period, when the person is not able to come out of the home, and especially when ultrasonography is not available easily, the urinary LH surge strips are a useful modality in which the female is supposed to use the midday urine, like not the first or the second sample of the urine in the morning, but preferably like after she has passed urine for 1 or 2 times. She can start doing it from day 10 or day 11 of her menstrual cycle. And it's a very simple test, just like a urine pregnancy test. And when she sees 2 lines on the urine LH strip, so that indicates that now the surge is about to happen. And within 36 to 48 hours of the LH surge, the ovulation will happen. So she can time her intercourse accordingly. So this is a useful test at home which can be done. Endometrial biopsy, previously recommended, is not is practically obsolete now in at least routine practice. Ultrasonography, I cannot overemphasize, it is the most vital investigation in the female. Sonography gives us so much information about the female anatomy, the uterus, whether there is any pathology with the uterus, like adenomyosis, fibroid, any abnormality. 3D ultrasound gives us information whether there is any anomaly with the uterus. And transvaginal sonography with a follicular monitoring can give us a very accurate information whether it is a PCO pattern, whether the follicles are maturing, they are rupturing in time, right? And if there is any pathology in the tube like hydrosalpinx or all, it can be seen. And on sonography, we can also see the endometrium, which is very important because after ovulation, the egg has to implant in the endometrium. So whether the endometrium is receptive can be, you can judge it by the thickness, the pattern, and the Doppler flow. Like Doppler can be used even in the follicle and even in the endometrium, and you can see how well the flow is, and from that you can take a judgment of how receptive the endometrium is going to be. So that was about the ovulation, like the investigations related to ovulation. Now coming to the second factor which can cause infertility is a tubal blockage, right? So for the tubal patency, the historical test which was done was the Rubens test. Nowadays, not commonly practiced. The hysterosalpingography is a important test which can be done, which is a low budget test with a low resource setting. You can do it. Sonosalpingography is also advocated, in which you use a pediatric Foley's into the uterus at the cervix and inject fluid, and you can see the fluid coming out. And it will obviously be added with other advantages of sonography, what you can come to the conclusion. Hysteroscopy is again always done along with laparoscopy. So hysterolaparoscopy combined can give us totally inside out of the uterus, what are the problems the female is facing. Like we can see the tubal ostia, we can see the uterine synecdoche, we can see the endometrial pattern, we can see the uterine synecdoche, any polyp or any septum inside the uterus, any foreign body inside the uterus. Especially in secondary infertility, suppose there is a history of a secondary infertility, suppose there is a history of a second trimester MTP, a retained bone can be a cause of secondary infertility. So this can be seen in the female. Laparoscopy along with the chromoperturbation, like loads of information. So a word about HSG is that it has a low sensitivity but a high specificity. And whenever you have an abnormal HSG, obviously you will go ahead for the laparoscopy. HSG is cheaper. It can be done as an outpatient. And if you do it under proper aseptic techniques, it has a low incidence of complications. But as I already said, that the method of choice is ultrasonography, that is the transvaginal. Now, what are the advantages of a laparoscopy? And mind well, whenever I say laparoscopy, we always club it with hysteroscopy. So it's always a hysterolaparoscopy evaluation of a infertile female. So what are the advantages and what things it can tell us is that from the point of the view of tubes, it can tell us whether the tubes are patent. If the block is there, it is on which side, the specific site of the blockage, the overall looks of the tube, like whether the tubes are pliable, motile, whether there is any hydrosalpinx, any adhesions, and what is very vital is the tubo-ovarian relationship. Like, how close are the tubes, the fimbrial end of the tube to the ovary to facilitate the ovum pickup. The laparoscopy will also give us the idea about the ovaries, whether the ovaries look normal or whether there are PCO changes, the typical egg-like shape and the look and the bulky ovaries of a PCO are characteristic. We can also definitely diagnose endometriosis, like grade 1, even a subtle endometriotic spots in the POD or on the uterosacrals or anywhere in the peritoneum or on the ovary, the specs of the endometriosis. So even stage 1 endometriosis can be picked up by laparoscopy. PID changes can be seen. Again, uterine abnormalities, fibroids, etc., can be diagnosed with help of laparoscopy. Peritoneal factors, as I said, adhesions, PID, endometriosis, and in our setup scenario in India, pelvic tuberculosis is also one of a very vital cause. And what are the advantage of laparoscopy is that besides being diagnostic, it is therapeutic at the same time. And Dr. Divesh Shukla sir, my teacher, he is also here in this webinar, and he's going to cover how you can treat infertility with help of laparoscopy. So these are the various case scenarios, but I'm not sure how much time do we have, because madam is going to cover the medical management and sir is going to cover the surgical management. Uh, so hello, how much time we have?
Ma'am, 20 minutes. It is for 1.5 hours and each is scheduled for around
I
20.
understand, but then I don't want to take the time of other speakers. So
Okay, ma'am.
because
So,
basic investigations I have discussed.
yes, yes, ma'am.
So
So,
now,
ma'am,
do you want me to go into case-based approach and all, or do we start sharing now? Like Dr. Sushma Bakshi, ma'am, she is also my teacher, and
yes,
she's there
yes,
to discuss the medical management.
yes, ma'am.
So
Okay.
yeah, so
So,
can you just ask the teachers who are present there that if they want directly now to go for the medical and surgical management, then I
yes,
can stop sharing my screen.
yes, yes, yes. Ma'am, Dr. Shushma, ma'am. Hello.
Yes,
Ma'am, should we continue with the medical management second session?
yes,
I
I
think
think
so. Later,
Yes. Okay, ma'am.
later we can have this case-based scenario.
Yes, yes, ma'am. Okay, so I would like to introduce the second speaker, and she's the
Should I
session.
stop sharing?
Hello.
Hello?
Yes,
Yeah,
ma'am.
can I stop sharing my screen?
Yes, ma'am. Thank you so much, ma'am, for the nice talk.
Yeah. Yeah, thank you. I will try to stay, but in case if there is a call from the hospital, I might have to go. So, yeah, but I'll try to stay.
Oh, oh, okay, ma'am.
Thank you.
Thank you so
Thank you
much.
so much for this opportunity. And
Yes,
yeah,
yes.
thank you.
you keep sharing the screen. Put your microphone off.
Okay.
Yes, sir.
Lionel, put your microphone
Okay,
off.
sir. I'll put my microphone off. Yeah.
Rest, yeah, rest other things would
Yes.
remain. Fine. Okay.
Okay. Okay, sir. So the second session is on the medical management of infertility to be taken by Dr. Sushma Bakshi. She is the head of the Oasis Fertility Clinic and IVF specialist. She is the director of Subeksha Multi-Speciality Hospital and Gopal Fertility Clinic, executive member of Gujarat ISAR, past president of SOGO and BOGS. She has also had a fellowship of WHO at Boston Harvard University in the past. So I request you to start with the session, ma'am.
Are you able to see the screen?
No, I'm not able to see.
Yes, madam.
Can I go ahead? Hello?
Yes, we can see.
No,
Yes.
go ahead,
Yes,
ma'am.
ma'am, you can start.
Okay. Okay. Good morning, everybody. And after having thorough information about the history and investigations of an infertile couple, the next management of infertility. Ultimately, friends, the aim of management of infertility is to have conception and have a birth of a healthy child. Infertility is a symptom. And it arises out of various social problems, emotional problems, medical problems, and to either of the male or the female. And Dr. Binal has nicely given the reasons why male infertility is there and female infertility is there. It certainly needs, whenever you are treating, it certainly needs an overall approach of a couple evaluation and skillful management. The objective of this presentation is to know incidence of infertility and various types, to study the factors affecting infertility in couple, different modalities of management of infertility in male and female, and overview of expanded horizon of assisted reproductive technique and scope and limitations both. So with these objectives, I go ahead with the medical management. Well, dear friends, in this time of lockout, I think that one important thing I suggest to all MBBS students is to go through the reproductive endocrinology chapter of yours, because once that is mastered, the treatment of infertility is easy for you when you will practice. The global prevalence of infertility is 1 in every 4 couple in developing countries had been found to be affected by infertility as by the WHO. Like, we have population explosion, but it doesn't mean that infertility is not a problem in our country. There are lots of patients, and as per the data, 1 in 4 couples, which is very high in incidence and prevalence of infertility. What is more important for us to know is that natural cycle pregnancy rate is something which one should know. Those couples after marriage, and when the lady is less than 30 years, 80% of them will conceive in 1 year of unprotected intercourse. 10% will achieve the objective before the end of second year. Rest 10% will remain infertile by the end of 2nd year, and they are dreaming of having pregnancy. So this 10 to 20% population we are to cater when we are going for management. They come for the treatment. This has already been told that it is defined as not being able to become pregnant after having regular intercourse without birth control pills uh, within 1 year. And that age is very important. If the lady is 35 years or older, for our country, I would say 30 plus, uh, you must start investigation early. You should not delay it. Uh, Primary infertility and secondary infertility definition has already been told. These days, people talk less than 30 years. It is more often said that the it is said as subfertility rather than infertility. The word sterility is almost now outdated. So this is a small video of ovulation, which I want you all to see. The release of an egg from one of the ovaries. It often stimulates one of the ovaries to release an egg. The wall of the ovarian follicle. So this is the ovulation, how it occurs. This is animation. The egg is released. And then there is Fimbria ovarica, pushes it into the neighboring fallopian tube. Towards the fallopian tube, and you can see the cilia held in part by contractions in the fallopian which propels. Here in the fallopian tube, the egg may be fertilized by a sperm. If the egg is fertilized, the egg and sperm unite to form a one-celled entity. So this is natural conception. The egg has been fertilized by the sperm. It begins dividing rapidly to form a cluster of cells. 2-cell, 4-cell stage. This is morula. And when it is blastocyst, that is the time it goes and implants into the uterine cavity. It's simply reabsorbed by the body, perhaps before it even reaches the uterus. And once it implants, the residual changes will occur and the pregnancy will ensue. So so once again, what I wish to say is that for normal pregnancy, you should have normal ovaries, normal fallopian tube, normal endometrial lining, the uterus should be normal, and the cervix and vagina should be normal for sperms to reach to the egg which is ovulated. This is the golden slide which I want everybody to check every time when you are thinking of endocrinological problem. In short, what I can say is that uh, for an ovulatory cycle, there is an ovarian cycle, and here up there you are seeing that how the follicles are increasing in size. There is ovulation, post ovulation there is corpus luteum, and gradually, if there is no pregnancy, the follicle explodes and what is more important is that this entire thing is governed by the pituitary, and we have FSH initial rise, which is normally initiates the process of folliculogenesis, and then there is a little dip in the FSH level, which is because of increasing estrogen level, and it has got negative feedback mechanism. Once the negative feedback mechanism is there, FSH goes down a bit. Around the same time, there is LH surge, and this LH surge will lead to ovulation. And the parallel endometrial changes will be there under the effect of estrogen and then after ovulation progesterone, which will allow the fertilized ovum to get embedded. So four cycles: ovarian cycle, pituitary cycle, ovarian response to pituitary by way of estrogen and progesterone, and endometrial cycle, they form the basis of conception. It is very important for us to know that the cause of male and female infertility are equally distributed. The 30% of the causes are due to female infertility, 30% due to male infertility, and 20% due to combine uh, male and female. Both are having problems of infertility. 20 to 25% are unexplained infertility, where we do not find any cause. The basics has already been talked by Dr. Beenal, so I'll not go into the details, except what is more important is that uh, the sexual history is a must. Like there are couples who do not know the fertile period, and that becomes a mechanical cause of non-conception. Obesity has already been told, and once the history and the examination part is over, the baseline transvaginal ultrasonography is to be done. And here you are seeing the uterus with triple line endometrium, which is periovulatory, and the ovaries. So what we see in transvaginal ultrasonography is ovaries, the follicles, and the endometrium and the myometrium, which is seen over here. This gives us an idea about the pathology of the uterus, ovaries, and many other lots of information one gets by 2D transvaginal sonography. The causes we know, and if we take them one by one, the infections can lead to infertility, endocrinal problems, ovulatory disorders, unexplained infertility. The uterine factor, tubal factor, endometriosis, which is because can lead add to uterine and tubal factor, and abnormal semen parameters. And we'll quickly go through one by one. The chlamydial infection is 20 to 30. In developing countries, it is known. However, we do not do routine chlamydia testing, but it can be done. The treatment is easier, like doxycycline 100 milligram twice a day for 7 to 10 days. And sometimes we need to treat the husband also for the chlamydial infection. These patients have complaint of foul-smelling leukorrhea, pelvic pain, and PID-like symptoms. Tuberculosis, when in India, we should not forget 5 to 10% of the infertility is attributed to genital tuberculosis, and the diagnosis, various diagnostic tests are there. These patients will come with either oligomenorrhea or amenorrhea and infertility. And once it is diagnosed by definitive methods, various lab tests, ultimately one needs to give AKT for 6 to 9 months. And if it is not advanced and endometrium is not affected, the patient would conceive. The bacterial infections are very common. Metronidazole tablets, 200 milligram 3 times a day for 7 days, along with vaginal paste, almost take care of all bacterial vaginosis as well as trichomoniasis. When trichomoniasis is there, one should give metronidazole to husband and wife both, and during that period they should abstain, they should not have intercourse, or they should use barrier method. And subsequently it will take care of the cure of the trichomonal problems. So that was about the infection. The common endocrinal problems, as Dr. Beenal has said, mainly thyroid and hyperprolactinemia. These are the two one which are major endocrinal factors which lead to infertility. Others I have already written, that hypogonadotrophic hypogonadism, PCOS, and hyperandrogenemia. So let us take them one by one. 2 to 6% of the female have hypothyroidism. What is more important to know is subclinical hypothyroidism, which 10% of the infertility is attributable to subclinical hypothyroidism, and thyroid autoimmunity. The effect of thyroid dysfunction on fertility. So how thyroid leads to dysfunction. So if thyroid levels are not normal, like TSH is high, in hypothyroidism, there is short luteal phase, there is failure of implantation, and it leads to early pregnancy loss. It is noteworthy to see that prolactin, TSH, and growth hormone, they govern the synchrony of FSH and LH. So any of this is abnormal, it will desynchronize FSH and LH and will lead to infertility. So the normal range of TSH, though it is said as 0.3 to 4, but upper limit of TSH is 2.5 milliliter unit per liter for those patients who wish to conceive. So if it is 4, you should give her tablets. She is subclinical hypothyroid, and then her TSH should be stationed at 2.5. The autoimmune thyroid disease affects 5 to 10% of the reproductive aged women. The thyroid antibodies are very high in this. It may be with normal TSH. So thyroid dysfunction may not be there, but autoimmune thyroid disease are associated with infertility. More than infertility, it is related to miscarriages. So those patients who are having recurrent miscarriages, you should go for autoimmune thyroid levels, thyroid antibodies level. So the thyroid has to be put to normalcy, and next is prolactin. Patients who are having hyperprolactinemia will typically come with you with complaint of galacturia, hypomenorrhea, or amenorrhea, depending upon the prolactin level. The normal level in man is less than 20 nanogram per ml, or for female less than 25 nanogram per ml. And it with the various levels of the prolactin, it may start with galacturia. With borderline rise, the periods will be regular in 30% of the cases. But with increase in prolactin levels, it will have an impact on the luteal phase, the ovulate, there will be more of anovulation, and then amenorrhea. In males, when there is hyperprolactinemia is there, it will lead to oligospermia, reduced libido, and uh, leading to male infertility. So the treatment is dopamine agonist. We have two of them available, bromocriptine and cabergoline. Cabergoline is very efficient in its working. It is to be 0.25 milligram tablets are available. Depending upon the prolactin level, you can give it once a week or twice a week, and it will take care of prolactin levels within 1 month of the therapy. So if you have a patient of hyperprolactinemia, you need to start the treatment in the previous cycle, bring about prolactin level to its normal, and then start with the infertility treatment. Coming to ovulatory disorders, the major problems are due to anovulation, which needs treatment. So in those 10% of the patient where infertility is there, the majority of the patients are having ovulatory disorders. And we have WHO group 1, group 2, and group 3 in this. Uh, Ultimately, either in hypogonadotrophic hypogonadism, it is the hypothalamus and the pituitary which is at fault. In group 2, where patients might be having irregular cycles and ovulation, but there may be polycystic ovary and hyperprolactinemia. And group 3 is poor ovarian reserve. Like patient might be 25, 30 years, but her ovaries are hardly having any follicles. So that leads to the ovulatory problem. Ultimately, one has to go for ovulation induction in these cases. So in hypogonadotrophic hypogonadism, we see the cases athletes are more prone to these patients having psychological problems, having anorexia nervosa, are having hypogonadotrophic hypogonadism and chronic debilitating diseases. It leads to, ultimately, if you go for the blood test of this patient, there will be low FSH, LH, prolactin, and TSH, either or all of them. These are the patients in whom we have to go for ovulation induction. They will not uh, behave well with oral ovulogens. So you need to give injectable gonadotropin, uh, and longer duration of stimulation is required to achieve ovulation. And LH supplementation is necessary. Polycystic ovaries, those who have seen sonography of polycystic ovary, it is so typical. They say is a necklace pattern that you will never forget. But for the diagnosis of polycystic ovary, you need to have Rotterdam's criteria. These are the patients who can have obesity, oh, sorry, I'm going back. These are the patients who are having obesity, hirsutism, polycystic like ovary, and their waist hip ratio is to be taken and BMI is to be taken. It is very important. So these Rotterdam criteria for diagnosis of PCO, it is there is oligovulation or anovulation, biochemical signs of hyperandrogenism, and polycystic like ovaries. So any two of these three, if they are positive, you can identify that patient as polycystic ovary. 20 to 30% of the population suffer out of polycystic ovary. The management is lifestyle changes, weight reduction, along with metformin, which is insulin sensitizer. There is some non-evidenced role of myoinositols and vitamin D in as a supplementation. Ultimately, you have to go for ovulation induction with or without IUI and IVF. The laparoscopic ovarian drilling and its role in PCOS will be talked by Dr. Divesh. The ovulation inducing agents are clomiphene citrate, letrozole, gonadotropins, with or without antagonist, and we'll take quickly one by one. Clomiphene citrate is a wonderful fertility drug in use for 40 years. The safety is assured. It increases pituitary LH and FSH to promote follicular growth. So clomiphene induces follicular growth and it doesn't induce ovulation. But the follicle which is developed out of clomiphene will induce ovulation by positive estrogen feedback mechanism. The dose is anything between 50 to 100 milligram a day for 5 days, maximum 150 milligram. There is no evidence that increase in the dose of clomiphene citrate beyond 150 milligram helps in ovulation. Maximum 6 ovulatory cycles should be given for the pregnancy treatment. If there is no pregnancy after 6 ovulatory cycle, one has to leave clomiphene citrate as a clomiphene citrate resistant case. The cumulative pregnancy rate with clomiphene citrate is 50 to 60% in 6 months. If it has not worked, like if there is clomiphene citrate failure, then the second drug of choice is letrozole. Nowadays in PCO, it is considered to be first line of treatment. It is non-steroidal aromatase inhibitor, and it blocks the conversion of androstenedione to estrogen. It is used for the treatment of breast CA in postmenopausal women, but for infertility, for a short period of 5 days, it is used 2.5 to in the 5 milligram dose from day 2 to day 7, and there are no side effects. It's a first line drug in PCOS and clomiphene citrate failure. Various gonad, if a patient doesn't do well with clomiphene and aromatase inhibitors, you can go for gonadotropins. These are injectable ovulation inducing agents. We have human menopausal gonadotropin, you have pure FSH, you have recombinant FSH. These are expensive. The limitation is it is an injectable form. Once you start with gonadotropin, you have to do first ultrasound monitoring to see the response of ovary. And there is a side effect like ovarian hyperstimulation syndrome and multiple pregnancy. It should be borne in mind. So gonadotropin should be given by the center where all the facility of monitoring and the treatment is available. As spoken by Dr. Beenal, the sonography is the mainstay. So when you start with any ovulation inducing agent, you need to monitor whether patient is responding to the treatment by way of sonography. So on day 2, you will have baseline scan and then start monitoring after 5 days of stimulation. You need to measure follicular number, size and endometrial thickness. It accurately predicts fertile phase. So antral follicle count is, you are seeing over here the small follicles which are seen over here less than 10 millimeter. They are antral follicles, and normally 10 to 12 immature follicles are there in normo-ovulatory patient. If it is less than 5, then it goes as a poor ovarian reserve. So you are monitoring with transvaginal ultrasonography, and when you see a follicle like this, which is more than 14 millimeter, the growth of the follicle then 2 millimeter per day. So you'll be able to know that when the follicle will reach 18 to 24 millimeter. And if this is what is seen, what we see is a small cumulus with a good flow. So that is a periovulatory follicle, and that is the time you can give HCG trigger to time the ovulation. So when follicle is 18 millimeter, endometrium is more than 8 millimeter, you can give 5,000 to 10,000 international unit human chorionic gonadotropin, and we can predict ovulation within 38 to 48 hours later. Um, Advantage of HCG is that it gives luteal support also. So with ovulation inducing agents and HCG trigger and natural normal relations, if patient doesn't conceive, then comes the ART procedures. Before going for ART procedures, you should rule out the need for surgery, and these are the ones which Dr. Divyesh will take uh, in his presentation, that which surgery when. But if there is no need of surgery, then one of the first treatment offered is intrauterine insemination. Previously, it was for oligospermia, but now there are other indications of intrauterine insemination. It is necessary to know that if you go for clomiphene citrate with IUI combination, the pregnancy rate is 8 to 10%, and if you have gonadotropin with IUI, it is 14 to 16%. So the combination improves the pregnancy rate, and the basic uh, technological and logistics which you need is shown over here. You should have laminar flow, insemination catheters and speculum, and media. The sperm is subjected to wash in media to remove the prostaglandins and other debris. And pure sperms, which are highly motile, they are prepared and injected into the uterus. That is intrauterine insemination. These are the indications which I have already said: ovulatory dysfunction, grade 1 and 2 endometriosis, male in subfertility, and donor sperm. When there is azoospermia and you are using donor sperm, you can go for intrauterine insemination. It should be tried in all the cases. And this is the schematic presentation, that the sperms are washed and prepared. They are taken into the cannula and injected into the uterus, uterine cavity. The IVF ICSI, she's Louis Brown, who is considered first test tube baby, but for Indians, she is the one who is uh, first test tube baby by a Calcutta gynecologist. Quickly, I'll not go into the details of IVF, but you need to have a very good lab for in vitro fertilization. The steps are follicular suppression, HPO-axis suppression, followed by controlled ovarian hyperstimulation, Then once the eggs are uniformly formed, they are aspirated by transvaginal sonography under anesthesia. They are fertilized in the lab, incubated, and monitored for the growth of the embryo. Once the embryos are formed, on day 3 or day 5, we go for the embryo transfer, and 14 days after the embryo transfer, we go for the pregnancy test. This is the schematic presentation of IVF. This is the uterus. These are the developed follicles with the transvaginal sonography. We aspirate the follicles. The egg is seen like this. It is subjected to ICSI with the sperm injected directly into the egg. The embryos are formed. This is day 3 embryo. This is day 5 embryo. And then embryo transfer is done with a soft catheter at into the uterus under sonography guidance. Sometimes you need three people to make a baby, because ultimate aim of a couple is to go for pregnancy. So when the ovarian reserve is very poor and no chance of having her own eggs, or the patient's eggs are bad, then one can go for the donor cycle and have the baby. So that is third party uh, ART technique. The success rate of fertility treatment depends upon, I would say, age 10 times, which is most important. Underlying condition like endometriosis or poor ovarian reserve or adenomyosis. Available services and its quality and competence. This is very important, because IVF is a highly technical process, and if the quality and the services are not up to the mark, even with IVF, the pregnancy rates will be very low. The gametes has to be good. If your egg and sperm are not good, whatever you do, there will not be pregnancy. And uh, one has to have good quality of life with less stress and obesity and other lifestyle problems which have to be managed along with. The success rate with IVF ICSI is 30 to 40%. With frozen embryo transfer, we have possibility of freeze the embryos if we are not transferring at the same time. The frozen embryo transfer 40 to 50%, donor eggs 50 to 60%, donor embryos 50 to 60%, and surrogacy 60 to 65%. That is the success rate. The ART techniques are not without any trauma or limitations. There's 2% risk of ectopic, 20% miscarriage rate, 30 to 40% multiple pregnancy rate, and that is why these days good ART centers are going for single blastocyst transfer to have singleton pregnancy. The failure rate is high. So those who are thinking that IVF, that means one will definitely conceive, should know that failure rate is high. Even premature delivery is high. Uh, Sexual disharmony and stress because of the treatment itself is there. For the male infertility, this is just one slide, but it is enough. Like, to the males, we have to say avoid tobacco, smoking, alcohol, and drugs. So reduce the stress, have healthy lifestyle, treat infections like gonorrhea and tuberculosis, give vitamin E and antioxidants. It is evidence based. Grade 3 and grade 4 varicocele need to be treated. Offer IUI or IVF for low count and motility. And when there is azoospermia with testicular low sperm retrieval, one can go for donor semen count. So the carry home message is that female and male infertility share equal percentages. So it is not that females are to be blamed for infertility. Normal cycles, BMI less than 28, normal semen parameters, and absence of medical problems with younger age give good success to the fertility specialist. Ovulation induction combined with intrauterine insemination improves pregnancy rate. Lifestyle changes and metformin along with ART procedures give better success in PCO. Surgery, when indicated, gives better outcome of medical management. Smoking, tobacco chewing, and alcohol consumption, when it is reduced, it leads to improved sperm count and motility. IVF and other ART procedures give better outcome if the woman is younger, and so it should be offered when it is indicated. With this, I thank Parul University, Dr. Komal, Dr. Gohil. If you have some questions, please contact me on this email, and I end my presentation over here. Thank you very much.
Thank you so much, ma'am, for the nice talk. And now I would request Dr. Divesh Shukla, sir, to please start with the surgical management of infertility. And before that, I would like to introduce him. He is one of the most eminent laparoscopic surgeon in Baroda and the director of Isha Hospital, which is a Foxy supported training center as well. And he was former president and secretary of Baroda Obs and Gynec Society, and he has served as a representative of Foxy. He has served as expert faculty in numerous laparoscopy workshops organized all over India, and he has many national and international publications to his credit. Sir,
Yeah, should I start?
yes, sir.
Yeah, thanks for your kind words of introduction. Hello, everyone. After having known the etiology and the medical management of infertility in male and female, what I would tell you in this presentation would be which surgeries would be required in male and female to optimize fertility, what preparation the patient should undergo before surgery, which are the, I'll tell you about the, very briefly about the pathologies treated. The presentation would not, we would not be able to tell you exactly how the surgeries and the complete method, it is out of the scope. Brief post-operative care and complications of such surgeries, and finally a video of patient with normal laparoscopy and hysteroscopic findings. The surgeries which are done in female and male, they're called as fertility enhancing surgeries, or they call as reproductive surgeries. And these surgeries are performed to improve the natural conception rate in infertile couple. We expect that following these surgeries, the patients would have a successful pregnancy. Dr. Sushmaven did say, whatever surgeries sometimes they are being performed, they are complementary to IVF. The success of these surgeries, they would depend, the success of IVF would depend upon the surgeries further performed. So the surgeries can be divided, these reproductive surgeries can be divided into a primary surgical treatment, which is offered to a patient who would have long-standing infertility. On ultrasound or examination, or on clinical examination, she would not show any pathology. Well, in these cases, instead of surgery, looking to current method of treatment, IVF would be preferred. You can offer a surgery to enhance the IVF outcome. These surgeries, especially, they are all hysteroscopic surgeries in female, and there would be varicocele surgeries in male. Now, these small amount, these surgeries would help increasing the outcome of IVF outcome in these patients, because these patients predominantly would require IVF as a method of treatment, and some pathology within the uterine cavity treated by hysteroscopy would help them to improve the fertility. Or else they are called as, the third variety would be fertility preserving surgeries. All those patients who would show some kind of pathology on ultrasound, transabdominal, transvaginal as tubal block, fibroids, endometriosis, or in male you have an evident clinical varicocele. These patients would be offered a fertility preserving surgery. Let's talk about some surgeries in the female. Which patients would require surgical treatment? They would be the patients who would have infertility with advanced age, with normal ultrasound findings, and have failed medical treatment. Especially beyond 30 years, the fertility rates gradually would decline. So we should act faster. There are certain pathologies which are not evident on ultrasound, and maybe surgical treatment of those subtle small pathologies would help in further management of these patients. The second group of patients would be who would have shown on transvaginal or transabdominal ultrasound various pathologies. The pathologies in the uterus could be a fibroid, could be an adenomyoma, or a structural problem as septate uterus, or would have Asherman syndrome or intrauterine adhesions as a part of trauma to the uterus when D&E was carried out in past in her, or some infection would have caused intrauterine adhesions. Within the ovary, you can have endometriomas, you can have endometriosis, you can have cysts within the ovary, or there can be a polycystic ovarian disease for which a female is not conceiving. The fallopian tube can show some pathologies. Some such pathologies may be evident on ultrasound, some may not. The pelvic adhesions can be predicted on ultrasound. Tuberculosis can be predicted on ultrasound. You can have hydrosalpinx, the dilated fallopian tube, which can be a cause for infertility. A tubal block which was detected on hysterosalpingography or sonosalpingography, or a para-ovarian cyst. These are the group of patients who would require surgery. To add the list, there can be congenital malformations in the genital tract, which would require some correction. You'll have to go through the list of malformation. I have enumerated some who would require correction. Following that, the fertility can improve in that patient. There can be vaginal cervical atresia, septums, longitudinal vaginal septums, imperforate hymen, intrauterine septums, non-communicating rudimentary horn, etc. There is a long list. After having known the patients who would require surgery, what is required? Now, these all patients who on clinical examination would show pathology, you will have to confirm on ultrasound examination, as stated earlier also, these pathologies, they have to be discovered, like they have to be said that whether it's a fibroid, whether it's a uterine pathology, whether it's an ovarian pathology, what is the extent of disease. If you say endometriosis, whether it appears mild, whether it appears moderate, whether it appears severe, all those things can be commented on ultrasound, or you can always judge on ultrasound. Various genital tract malformations also can be diagnosed on 3D ultrasounds. If required, if you want to know further knowledge regarding the genital tract malformations, MRI also may be required, which would help you in correctly identifying the genital tract malformation. But these all ultrasound findings and clinical examination would help us in planning the pregnancy, what exact surgical management is required in that particular patient, and these are all conservative surgeries which we are talking. Before ultrasound, before surgery, after ultrasound, X-ray also is done as a part of pre-operative fitness. Once we decide that this particular patient would require surgery, what next? We will have to evaluate the general condition of patient. We'll have to diagnose pre-existing medical problem. We'll have to assess a cardiac and pulmonary function. Now, these are the standard things which are required to a patient to undergo for any surgery, any major surgery. They are being said here also for even for laparoscopy and hysteroscopic surgery which you would undergo. This would be required. This would be required for safer anesthesia and surgery. So there is a list of investigations she would undergo as complete blood counts, urine examination, fasting blood sugar or postprandial blood sugar, or resting blood sugar as routine sugar levels as per requirement, the liver function test, the kidney function test as serum creatinine, HIV and HbS-Ag. These are the basic tests which the patient would require before surgery. It is also mandatory whether the patient is young or the patient is beyond a particular age. A definite cardiac evaluation also is required, as we will have to carry out ECG and echocardiography or stress echocardiography depending upon which patient are we looking at and what's her age and what is a medical condition. After comprehensively examining the patient, we will have to have a physician who would see the patient, would find out the surgical risk in that particular patient, physician, anesthesiologist consultation, both are required, so that we can carry out we can know the risk of anesthesia for the patient. Accordingly, we can explain the patient, this is the risk which you have when you would undergo a particular surgery. These are based on the patient's examination finding and based on the investigations which had been carried out, as you know. Still, everything isn't being done. Before scheduled surgery, we'll have to take an informed consent of the patient, and patient and the relative would require counseling. A detailed consent of the patient is very much required. Patient and the relative in their own language, and she should completely understand about the surgery. She should be be told completely what are you going to do, and what are the results expected following surgery. All these things are necessary. Only then you can schedule the patient for surgery. Preoperatively, you should know that the patient should remain nil by mouth overnight. The lower bowel enema is usually sufficient for laparoscopy and hysteroscopic surgeries. Patient can be given anti-anxiety medication at night, and shaving off parts, if required, may be done immediately before surgery. Laparotomies. Let's talk about the surgeries which are required. Laparotomy is not performed as fertility enhancing surgery. Laparotomies are never performed in this era. Either it's a laparoscopic surgery or hysteroscopic surgery, and these surgeries are done under general anesthesia. Both hysteroscopic and laparoscopic surgeries are therapeutic minded. We don't talk about diagnostic hysteroscopy and diagnostic laparoscopy. While performing laparoscopy and hysteroscopy, if we happen to see a particular pathology, we have to treat that pathology. So they are not called as diagnostic, which often the terminology is being used. So pathologies found or pathologies which are found, or the pathologies which had been suspected on preoperative examination and ultrasound, they are confirmed on laparoscopy and hysteroscopic examination, and they are completely treated. So these are fertility enhancing surgeries. There is a list of fertility enhancing surgery. When you see the list here, tubal cannulation with wiring for proximal tubal blocks. There are many patients who on HS hysterosalpingography or sonosalpingography are reported as having tubal block, and these are proximal tubal block being reported, and these are non-obstructive tubal blocks which are being relieved by tubal cannulation surgery. If the patient has fibroid or adenomyoma, laparoscopic myomectomy or laparoscopic adenomyomectomy is carried out. Patients who have ovarian cyst, it can be an endometrioma also. There, a cystectomy is being carried out. It can be a dermoid cyst in the ovary. Patients who have polycystic ovary who fail to respond to medical treatment, and after adequate medical treatment and they show some androgenic features, would require laparoscopic ovarian diathermy. LOD is an abbreviated terminology which is being used, which would destroy the androgen theca cells of the cortex and would reduce the androgen production locally from the ovary, and the patients now are responsive to medical treatment. That's how this particular surgery would work. Fimbrioplasty would mean, when I'll show you some pictures where these surgeries would become more evident to you. When the fimbria are blocked terminally because of flimsy adhesion, you would cut those adhesions and open the fimbria. Salpingo-neostomies are done for hydrosalpinx. When the tubes are blocked, you try to make a new opening. Because of pelvic inflammatory disease, there are adhesions in the pouch of Douglas. The tube and ovary, they can get adherent to each other. That's called a salpingo-ovariolisis. Coagulation and excision of ovarian and pelvic endometriotic lesions. Endometriosis, as you all know, it's an ectopic location of endometrium other than the uterine cavity when it is located in the pelvis. and various genital organs. They call as endometriotic implants. I'll show you the pictures of those implants. And then tubal recanalization. Suppose the patient had undergone tubal ligation. Now she requires fertility, so she would require tubal recanalization surgery. That's secondary infertility that would result because of tubal sterilization. So you open up laparoscopically then. Laparoscopy is all about creating primary pneumoperitoneum. In the picture you see here, this is a Veery's needle which is inserted through the umbilicus to create pneumoperitoneum. Once the pneumoperitoneum is created, you insert a primary trocar here and then the ancillary trocars which are inserted. About 3 such trocars are being inserted. This through the primary trocar, which is 11 millimeter, you use telescope to visualize the intraperitoneal structures, and through these small 5 millimeter trocars, you're going to insert hand instruments to operate the patient. On ultrasound examination, there can be single or multiple uterine fibroids which can be seen. By laparoscopy, you carry out laparoscopic myomectomy. This is the uterine muscle which has been cut and the fibroid which is popping out, and the fibroid is removed. And the remaining myometrium is now sutured. So these would be the end result. So lap myomectomy, there can be one or there can be many such fibroids at different locations in the uterus and cervix which are being removed. That's called as laparoscopic myomectomy. For proximal tubal non-obstructive block, tubal cannulation procedures are being done. The below 2 pictures are of hysteroscopy. I'll show you hysteroscopy also, where a cannula and a guide wire is passed through the ostia, the tube which opens inside the corneal area of uterine cavity, and the wire is pushed ahead and it comes out through this interstitial and isthmic area, and the block here, it's getting relieved. This is an area where the wire has come out. The non-obstructive block gets released once the wire goes ahead beyond this point, and after you withdraw the wire and carry out chromoperturbation, I'll show you that also. Dia would seem be coming out through the fimbrial end, would indicate that the fallopian tube has become patent now. We were talking about laparoscopic ovarian diathermy. There are patients who would require, there are certain criteria, set criteria for a patient to undergo this procedure. For you have to remember that if this particular procedure is only meant for patient who fails to ovulate or would require large doses of gonadotropin to ovulate, would require laparoscopic ovarian diathermy, so that her medical, while using drug, she responds better to medication. It's all about using monopolar current here by a needle which tries to destroy the ovarian cortex at multiple level. This is the uterus, these are the ovaries, that's fallopian tube, and through this needle there is a definite needle, a definite depth, and a definite current which is used for this particular procedure. You cannot be erratic to carry out this procedure, otherwise this would destroy the ovary, would cause ovarian failure in a given patient. So depending upon the overall ovarian volume, the number of such damages are being done or punctures are being made onto the ovary unilaterally or bilaterally. So that's laparoscopic ovarian diathermy, which is being used for patients who have polycystic ovarian disease. Adenomyomectomy. I'm sure that you would know the word as adenomyoma. Whenever the ectopic endometrium is implanted within the muscle of uterus, there is a hypertrophy and hyperplasia of muscle. There can be a diffuse adenomyosis or a focal proliferation of muscle, which is called as adenomyoma. Here, adenomyomectomy procedures, they are all partial resection. So an energy source is used. The energy source which is used for lab surgery can be an ultrasound energy source, or it can be electrosurgical energy source. So this helps in cutting that area. Adenomyomas are always partial resection because they are all diffuse tumor. They are not localized. So that's how an adenomyoma would look like. You cut here, remove the adenomyoma, and then suture the remaining myometrium. Endometriosis as a term, these are various pictures of superficial and deep endometriotic implants. This is a picture where a needle is excising this endometriotic lesion. This is a picture of stage 3, stage 4 endometriosis, where you see vesicular lesions. Endometriotic lesions in the pelvis can be of different color. They can be red, they can be brown, they can be dark blue in color. You can see pelvic adhesions. They can be white lesions. Here the uterosacral ligaments are being excised. Other than excision, the superficial lesions, which would be about 2 millimeter deep only, you can use a bipolar current to destroy those lesions or coagulate those lesions. This is a bipolar instrument which is coagulating. This is pouch of Douglas. The uterus is anterior. This is also a picture of pouch of Douglas. These are uterosacral ligaments seen here. This is one of the uterosacral ligament which has a lesion. The same picture. So endometriosis is it's complete destruction of visible endometriotic lesion by laparoscopic surgery. That is the surgery being done. When you have endometriotic implant within the ovary will become large like this, would have a cyst here, which is called as endometrioma. Generally tends to be adherent in pouch of Douglas. This is adherent. You can see brownish content here. While separating this from adherent pouch of Douglas, you would see brown content draining. That's chocolate content. And see here, that's also a uterus, both fallopian tubes, both ovary, and then endometrioma. And here, this endometriotic cyst wall is completely removed. And if necessary, this ovarian cortex, which has been opened up, might be sutured. So it's an excision of ovarian endometrioma. In this picture, hydrosalpinx is a dilated tube which is filled with fluid inside. These are both dilated tube here. That's again a hydrosalpinx. This is again a hydrosalpinx, and the monopolar needle here opens up the hydrosalpinx, makes a new ostia. So it has been drained and new ostia has been made. This surgery is called as salpingoneostomy or cuff salpingostomy also is the word used. In presence of infection, you can have adhesions within the uterine cavity. These three are hysteroscopic pictures, and the scissors are cutting adhesions within the uterine cavity. These three are laparoscopic pictures. The ultrasound dissector and the scissors, they are trying to cut the adhesions. This is small bowel and this is peritoneum. Here also, the adhesions which are being cut. You can see the adhesion between ovary and the lateral border of uterus. Same adhesion between ovary and lateral border of uterus. That's uterus here. This is ovarian ligament. This is fallopian tube. Here also, the adhesion between uterus and the fallopian tube. So these surgeries are known as salpingo-ovariolysis. You're trying to lyse the adhesions around the ovaries, ovariolysis. And the further adhesions which are seen here, which they're being cut. You can use scissor or a monopolar current to cut those adhesions. The ovarian cyst can be of different variety. They can be simple functional cyst of ovary. It can be a dermoid cyst. It can be endometrioma, as you saw. It can be cyst adenoma, which you saw. All those cysts would require surgical excision. The same different cysts seen here and you would remove the cyst, and then you might suture these ovarian cortex. Serous cystadenomas are being shown here. This is an endo bag. Generally, cyst excisions are done. The cyst are
Sorry,
kept.
sir. Sorry to intervene, sir. Actually, there is a time limit. 2 minutes are still there, sir. Okay.
Yeah, I'll finish within that time. Don't worry.
Thank you.
And then some fimbrial cysts which are there, which you tend to remove when you see them. During hysteroscopic examination, when you see intrauterine septum, you can resect this. This is a bipolar resectoscope. Bipolar saline resectoscopic surgeries are being done to treat intrauterine structural defects as septate uterus or metroplasties, intrauterine pathologies as fibroid within the uterine cavity or polyp within the uterine cavity. These are multiple polyps which are seen are being resected by resectoscope. I think when the students are logging in, they would not have seen any such pictures. It's better that they see such pictures. Time limit here, plus minus 5-10 minutes, should not be much a problem, because I don't think they would have seen these pictures anytime. And talking to them and showing them these pictures should benefit them. They should know what a polyp should look like, or at least they would have in their mind that there is something like a polyp in the uterine cavity, and there is something which is called as a hysteroscopy and resectoscope, which treats the polyp. So that's how it would take little more time. Otherwise, we can wind up within no time. We can just stop. They would not know anything. When you're talking about infections, the tuberculosis, as we said, it's very common. Hysteroscopic examination also would show some caseation within the uterine cavity, and the micropolyps or such variegated appearance seen would indicate that there can be chronic endometritis. All these patients would, unless treated, would not have benefits out of medical treatment. So they would require treatment by, if there is a tuberculosis being diagnosed, or when you have chronic endometritis, you take a biopsy, document chronic endometritis, and then treat. The tubal function also can be known by doing salpingoscopies. It's all about looking within the fallopian tube to find out how are the mucosal folds within the fallopian tube. It's distal half of fallopian tube which is looked at, which is called a salpingoscopy. So you saw these you saw hysteroscopic surgeries and a group of laparoscopic surgeries and a group of hysteroscopic surgeries, polypectomy, myomectomy, intrauterine adhesions, corneal dilatations, and septal resections. These are the surgeries which are generally required. Post-operatively, the patients are kept nil by mouth for 4 to 6 hours only. Prophylactic antibiotics are given. Generally, patients, they do not require any self-retaining catheterization. Early ambulation is opted for these patients, and they are discharged within 1 to 2 days. Generally, they are being followed up on day 5 and day 8. On the day of stitch removal on day 8, they should be advised regarding subsequent follow-up visit and the further plan of treatment. That's how the complete surgical plan would go. Intraoperative complications, the risk is low generally, and it's about 1.4 per thousand population. The risk of intraoperative complication, they are in the range of 0.1 per 1,000. Anyway, the risk is low, and the risk is divided depending upon what pathology are you treating. The risk is related to the entry and then the surgery which is being performed. More complicated surgery, more risk of intraoperative complication. Post-operatively, there's a likely possibility of patient having fever or some peritonitis because of bowel injury, or bowel obstruction can result because of peritonitis. Patient can have secondary hemorrhage, or can have early recurrence of disease if the surgery is not adequate. Talking about a minute about male, in today's era of success of IVF, less surgical options are given to males when there are reduced count, oligozoospermia, when the motility and count are low, because IVF with ICSI treats all forms of male infertility with severe oligozoospermia also. IVF ICSI is more indicated and surgical results are not very predictable. The various surgeries which are being offered are varicocelectomy, that's a microsurgical occlusion of varicocele when clinically diagnosed, and ultrasound had proven increased diameter of vein more than 1 millimeter. When the vas difference is blocked, you can offer them vasostomy, vasoepididymostomy is done. Testicular biopsies exactly are not done today because investigations we can find out what is testicular biopsies were done earlier in patients who had azoospermia to find out whether spermatogenesis is happening or not within the testes. Importantly, these surgeries are more important today. The techniques of sperm retrieval, which are necessary for IVF, they can be microsurgical epididymal sperm aspiration, which is called as MISA, percutaneous epididymal sperm aspiration, which is called as PISA. Testicular sperm aspiration and testicular sperm extraction are the common surgical methods for sperm retrieval today, which are in practice. Ejaculatory duct obstruction surgeries, you can read out through the transurethral resection of ejaculatory ducts would solve the problem of ductal obstruction. And in case of patients who have failure of ejaculation, electroejaculations are being tried. To summarize, laparoscopy and hysteroscopic surgeries, they would effectively treat various structural and pathological causes in female responsible for infertility. In majority of cases, correction of these abnormalities alone would result in spontaneous pregnancy, or else they would require additional medical treatment following the surgery. With advance in technology and the instrument, the surgical results have started improving much better. In male, generally, the decision for surgery is deferred, and by various sperm retrieval method, IVF with ICSI is the method of treatment plan for patients who would have severe oligozoospermia. This is a video of hysteroscopy, a telescope which would enter through the cervical canal into the uterine cavity. And once the hysteroscope enters the uterine cavity, you would see the normal looking cavity. That's one of the tubal opening which opens up at the cornu. That's another opening. They should look like this only. When you have a closure look here, you can see this endometrium and the white spot seen. If they are seen clearly here, they are the glandular openings which are there. So this is a normal hysteroscopy examination. On laparoscopy. That's the uterus seen here. When you're trying to inject methylene blue, through the cervix by a cannula, you would see this is the fimbrial end. You can see the dye which is coming out through the fimbria. These are the that's chromoperturbation to know the tubal patency. Pelvis appears normal. The ovary, both fallopian tube, they appear normal. This is a round ligament. That's the uterus. Uterosacral ligament. That's pouch of Douglas. So this is a normal laparoscopic examination finding. Lift up the ovary. Look at the pelvic peritoneum. This is the ureter, which is seen the normal. You can see some adhesions here, subovarian adhesion. Which you remove. There are other additions which would get removed. Anyway, with this, I finish my presentation here. I thank you, and if you have any doubts, you can write to my onto my email ID. I should be able to respond to you.
Thank you so much, sir, for a wonderful presentation, and those videos were a visual treat. There are few questions that have been asked, and one question is to Dr. Sushma that if a patient for infertility comes, then should be when to offer HSG, like they should start treatment before empirical treatment like clomifene, and if she does not respond, then you should offer, or before only we should offer, or and also there such cases where we should straight go for diagnostic report and not do HSG.
So, your voice was not so clear, but as I understood, if a patient is having no other complaints and has just come, should we go for ovulation induction? That's what is the question?
Yes, ma'am. Should we do HSG and then go for ovulation induction if she has no other history, like no significant history?
No, if she is a case of primary infertility, generally tubal pathologies are having very low preponderance in primary infertility cases. And if patient is having oligomenorrhea or irregular periods, these are the cases who are likely to have ovulatory problems. So in those cases, you can straight away go for ovulation induction and go ahead with almost 3 ovulatory cycles, and within 3 ovulatory cycles with normal semen parameters, if she doesn't conceive by regular timed fertile period intercourse, then one can go for higher treatment, and before that one can go for tubal testing.
Okay, thank you, ma'am. And ma'am, if there is some pathology, then we should directly go for diagnostic histolab rather than some
Yes, I
like
mean,
some.
it depends upon the extent of pathology and which pathology is there. Like fibroids. If fibroids are not indenting into the endometrial cavity, they are superficial or subserous fibroids. They are not the cause of infertility in those cases. So straight away going for surgery in those cases where there is only subserous fibroid, one need not go for surgery. uh, Similarly, grade 1, grade 2 endometriosis, though it is diagnosed by laparoscopy, but by chance, if the endometriotic cyst is very small, like less than 3 centimeters, then one need not go for straight away surgery unless the patient's age is high. Age is very important. Like 25 years old patient with a small isolated endometrioma with free mobile uterus, one can try with the ovulation induction and IUI and give her some time for the conception rather than going for surgery straight away. But bigger cyst, bigger fibroids, more of adenomyosis, tubal hydrosalpinx, one need to go for surgery first before going for ovulation induction.
Okay, thank you so much, ma'am. My next question is to sir. Sir, actually, suppose in a primary infertility patient, during doing a diagnostic history lab, we get to know that there is a endometriosis and with large ovarian cysts like endometriomas, like around 8 to 10 centimeter. And if it is the rectum and all is red, then to what extent should we proceed? Like if you are not that confident in about that rectum and everything, to what extent should we proceed so that it is in one way useful for the patient, like for the infertility part is taken care of?
No, no, you have to carry out a complete surgery for that particular patient.
Okay. So rectum, we have to do everything completely, like for infertility, sir.
Yes, yes, you have to carry out everything. If you think you can't do it at that particular moment, you might not do anything, and then call an expert to finish rest, because the first surgery being done should be properly done, which is categorically said by everyone, because inadequate surgeries performed, they can create more problem in this group of patients. You're telling the patient having 8 centimeter, 10 centimeter endometrioma, so that's a significant large endometrioma expected to be having more pelvic disease also. So it has to be properly done. First attempt, everything should be cleared. The deep rectovaginal disease which is there coexisting, you may not do anything unless you have talked to the patient, but that doesn't interfere with fertility. But pelvis
Oh,
should be cleared completely.
yeah. Thank you so much. Thank you so much, everyone, for the enlightening us on the topic of this infertility. I hope our students have had a good, they have had good information on this topic, and they will be able to, answer all the questions further. Thank you so much. Thank you, ma'am.
Yeah, thank you. Thanks everybody.